Okay, so all right. I guess I might as well start talking then. So welcome to this special Mobility Monday that we're doing through the O&M Specialist Association, focused on the uh, Certified Vision Rehabilitation and Occupational Therapy certification from ACVRP. And I'm Justin Kaiser. I'm recently taking over as the president of OMSA. And we have our guest kind of speaker tonight is Dr. Ann Rittering, who has a PhD and is also certified as an occupational therapist, O&M specialist, and low vision therapist, and works for the Henry Ford Health System and Western Michigan University. Thank you very much for talking with us tonight, Ann.
Sure,
Um,
I'm happy to be here. Thank you for inviting me.
and I think Ann has a few things that she's gonna kind of go over just about the certification, and then we'll kind of take questions and comments after that.
Sure. Thanks, Justin. I did prepare a PowerPoint, so I am going to share that with you. Let's see if I can get it on here. Excellent. Um, so just a little bit about my background. So I started as an OT first, worked for a couple of years just doing general rehab, and ended up going back to school to get my O&M degree. So I've been in the field for about 28 years now as an O&M, longer as an OT. And I've done vision rehab my entire career. So I've worked in an interdisciplinary setting where we have an O&M, we have CLBTs, we have an OT, we have an ophthalmologist, and optometrist. So I think I come from a very unique perspective because I have been doing this for so long. And as I said to Eileen, I feel like I've been talking about OTs and collaboration with OTs for about 28 years now. So our goals for today is just to explain the purpose of the development of the new ACVREP certification for OTs. I want to kind of have you understand the eligibility requirements and understand how OTs and other vision rehab professionals can collaborate. And then hopefully we'll have time to answer some of your questions. So first of all, I thought I would put all of the subject matter expert committee names up here so that if anyone wants further information, all of us are more than happy to talk to people and answer questions, as I know Kathy Zeider is as well. So first, why is the certification being developed? And there's a number of reasons. Number one is there is a rising number of older adults with visual impairments. As we all know, the baby boomers are getting older, and that is a very large generation. And so they are going to need more services. There will likely not be enough doctors. There will not be enough physical therapists. There will not be enough nurses to serve this population. And included in that, there are not enough vision impairment specialists, people who work with vision loss, to service the need of these people. In addition, a large number of baby boomers are retiring. So if we look at the population of professionals who are out there now working, many of these people are going to be retiring as they age into that, into kind of the age group of the baby boomers. They are all retiring. So that is also going to create a problem with providers servicing that older adult population. Every person with a visual impairment deserves to receive services from trained professionals. And so that's one of the goals of this certification, is to make sure that people are trained. So right now there's approximately 4,000 certified professionals, and not all of these vision rehab professionals serve adults. So we know there's not enough new professionals entering the field to replace that large number who's retiring. And that's creating, a big problem. There just aren't enough providers out there. For the longest time, until Leader Dog started their mobility program in the Detroit area, I was the only O&M, certified O&M, serving the older adult population in the Detroit area. This is a huge city, and that's a big problem that I was the only one. Um, and it was a couple of years ago when Leader Dog started their mobility program for just training patients to move around the environment, not necessarily for dogs, but it's usually white cane training that they are doing. So we want to make sure that we're all providing the highest quality of care. Just like O&Ms get certified and VRTs are getting certified and low vision specialists are getting certified, we want to make sure that those OTs possess the right skills to service this population. So a little bit about the history is AOTA, which is our professional organization, used to have a certification, and it used the delineation of SCLV. It was Specialty Certified Low Vision OT, and that was discontinued. And so it's honoring that credential. If you have that credential, you can still use that credential, but they are not allowing anybody else to get that credential. So no one else no new people who are interested can get that certification anymore. When we look at the CLVT, there are some gaps in that certification that don't cover everything that an OT can do, or that can address. It doesn't address the OT specialty skills, which we're going to talk about how we're trained to work with the population. And so there really is some gaps. So the certification really aims to increase access, right? Increase the number of qualified professionals, so there's more access for people who need it. We want to make sure that we define and ensure that we have professional standards in place so that OTs have the knowledge they need to serve this population and also the skills necessary. And then we want to build on the current skill set of the OT. So we want to expand the OT's body of knowledge, our current one that we come out of school with, that, after working, that we have. We want to make sure that there's a scope of practice set for them so that they know what is acceptable for them to be doing and not. And then we want to make sure that they have experience to do this. And then the last thing is ideally, as everybody in this call today wants to do, we want to improve the lives for consumers, right? We want to improve their ability to live independently. So in a nutshell, the OTs who are seeking the certification will need to meet certain criteria and follow certain standards, which is laid out in the document that CVRAP posted. So first of all, they are going to need to meet eligibility criteria. In that criteria are certain things like their schooling, right? They have to have a certain level of schooling to get their OT degree, and so that's the one standard that was set, similar to O&M and VRT as well. The second criteria is we want them to have worked, because this is a certification for adults, let me make that clear. We want them to have worked with the adult population for 3,000 hours before they think about getting this certification. And the thinking behind that is really so that we know that they know how to interact with patients, that they're comfortable assessing patients, and that they have a good foundation to build on for the vision component that we're adding. And then there will be specific criteria that they have to meet for hours of service working with people with visual impairments. And it will include low vision and neurological impairments. And there are certain things that they have to learn to do to assess and to create interventions for patients. And then the last component is kind of resources and referrals that they have to know about. And these are laid out in the competencies for them. The last thing that they will do is they will complete their mentorship and pass the ACVRAP exam. So very similar to what like a CLVT might go through as well. So first, I thought we would just talk about kind of what's the background of OTs. And there's, just so that you know, there's something like 230,000 OTs in the US. Not all of those are going into low vision. A very, very small percentage of those are going to do vision rehab. And so, everyone thinks that the field is going to be inundated by OTs and things like that. It's not. There will be, a number who decide to get the certification, but there's not going to be 10,000 people going into this. Kathy Zeider from ACVREP probably hopes that there is, but I don't foresee that, happening. But the training of a generalist OT is currently at a master's level degree. We are not doctorate level. The OTs several years ago decided that they did not want to go to a doctorate level. We have background in basic sciences, so biology, psychology, anatomy, physiology, physics, kinesiology, and neurology are all taken for OT programs. We have a background in kind of medical conditions as well. We know about disease processes and how each affects the body structures. And so we might be looking at body movement, including balance. We might be looking at cognitive and psychological impairments. We might look at limitations due to chronic conditions. There are many things that we can look at and kind of analyze that has to do with movement and the body and how somebody is functioning. We have very specific classes on aging, mental health, cognitive function, and pediatrics. So you come out of school as a generalist OT, not a specialist. And so that's where the certification will help hone in on some specialty skills that are needed to work with that population of people with visual impairments. So we, in general, assess limitations to participation in daily living activities. Daily occupations is what we call them. And we do this by analyzing activities and looking at safety during ADLs and movement during ADLs and kind of breaking down where is the problem and what's causing the problem. If I'm going to use a low vision example here, but if I'm using, let's say, a magnifier of some kind, is it a hand tremor that's causing a problem? Is it a cognitive function that's causing difficulty because I don't understand the focus distance and where I have to hold it, something like that. So there's lots of things that we're kind of analyzing as we move forward. We have definitely have evidence-based assessments and interventions that we use as well. There's quite a bit of research behind what we do and why we're doing it. So the other thing to realize is all OTs work under doctor's orders. So we have to have a prescription written by a doctor in order to provide services. We are, in general, part of a multidisciplinary or an interdisciplinary team. So we work quite often, and we refer back and forth to, but we work closely with physical therapists, speech therapists, nurses, respiratory therapists, social workers, counselors, audiologists, recreation therapists, certified driving specialists, certified diabetic educators. We work with a host of people already. And that's, I think, really important for everyone to understand, because that means OTs are used to referring to other disciplines. So they're used to referring to other members of the team in order to get better, to address the needs of their patients. We have 2 internships there's 2 levels of internshipping that we do. One is called a level 1 field work, and it's usually concurrent with courses. And so every school does it a little different. Sometimes you're going once a week for a placement. Sometimes you do 1 week at a time. It just depends. And then we have a level 2 internship. And there is, and you have 2 of these or you have 3 of these. It just depends on, again, your school and what your interest is. And each is 40 hours a week for 3 months. So very similar to what I did for O&M school. So it's 6 or 9 months total working full time in a certain setting. Um, and so your settings for those 2 internships rotate. So you have 2 or 3 different settings that you're working in to get your skills. And then after our coursework is done and the internships, we have to take a board exam, and you are not allowed to do that until you have finished your interning and passed your courseworks and, your coursework and your internships. So once you do that, you can practice as a general OT, or you can work in a certain area to hone your skills in certain things. So you might be a hand therapist. You might focus on neurological rehab. You might do mental health. You might do pediatrics. You might specialize in return to work. You could work as a lymphedema specialist. You could do driver's rehab. You could, of course, do low vision or vision rehab. You could be an assistive technology specialist. So there's many, and there's some that I am forgetting. So, but there are many things that you can do as an OT depending on the setting and your interest area that you might work in. And some of these do have specialty certifications that you can go for, like hand therapy, for instance. You can become a certified hand therapist. There's a neurological specialty certification that you can get as well. So there are other specialty certifications that are out there for OTs. So if we talk a little bit about the new certification, and I alluded to this a little bit, eligible applicants must meet all the educational requirements. So to become an OT, here's what you have to have. And then again, as I said, we have stated in the documents that 3,000 hours of experience working with adults in the past 5 years. So we don't want, since this is a certification for adults, we don't want somebody who works in pediatrics to be able to get this certification. We want to make sure it's for people who are working with adults. We want people to complete a mentorship program. And we use that term because if we use the term internship to OTs, it means something totally different. So interning is, that 40 hours a week, it is unpaid. And so we don't want people to get this thinking that they have to do it all in 40 hours, over the course of several weeks' time. So we've called it a mentorship, but in all intents and purposes, it really is their internship program. There are key competencies that they are going to have to demonstrate. They will have a mentor for this, kind of a supervisor for this certification, similar to the CLVTs, that will mentor them and teach them and watch them do things as well. And the key competencies encompass about 7 pages. So I think I have a picture of some of them coming up. They have to pass an exam. They're going to agree to a code of ethics as well, just like the other certifications. And then there's pathways for eligibility. And technically there's 6, but we're going to talk about those and just make it a little bit easier to understand. So there's really only 3 if you think of it that way. So there's the formal graduate program, if they go through a formal low vision rehab educational program, and there's several. UAB is one of them that has a graduate certificate program. Salus, I don't know if Salus still has theirs, but at one time they had a master's program that OTs could be in to get a low vision certification as well. You can do an autodidactic, which is the self-study route, right? And so if you look at the CLVT certification, there is a self-study route to that, and that's what this is based off as well. And then the third pathway, the third general area, is OTs with other with ACVRAP certifications. So there's there's OTs could combine their OT degree and have a number of different things. And I think I've met all these people working on this committee almost. So you can be an OT and be a CVRT. You can be an OT and a CLVT, or have that specialty certification from the OT organization, which is the SCLV. You can be an OT in comms. And although there aren't many of us, there are several of us that are out there. Or you can be an OT who holds multiple certifications. You might be like me and hold an O&M and a CLVT. And so we had to define, like, some of these people have different, experience than somebody else. And so that's why it seems like there are so many categories. But there's really, when you look at it this way, there's really not that many categories that you can do. So the mentorship is the base number of hours is 350 hours. And in the eligibility criteria, we've defined kind of what counts as direct service hours and indirect hours, which is very hard if you've ever mentored somebody to understand. Like, if you look at the CLVT one, I always have questions from people I'm mentoring about, well, what counts as this and what counts as that? And they're not really sure. So we've tried to define it a little bit of what counts. And we really wanted, patient care hours, basically, face-to-face with the client, or training their family members or care persons to count as direct service hours. So there's a couple of other things as well, but that's the majority of that. The number of hours that's required is based on your experience. So if you already have your CLVT, you shouldn't have to repeat hours to get the low vision hours. If you already have an O&M degree, you shouldn't have to maybe repeat, or VRT, maybe you shouldn't have to repeat blindness skills training or something like that, but you need low vision hours. And then there's also a number of neurological hours that you have to get. So if you look closely at the eligibility criteria and read it, it's kind of starts to make sense the way it's been defined, because it's based on how much other experience you're bringing to the table as well. So the couple of things to remember is that the body of knowledge and the scope of practice that were posted are really building on the knowledge of what the OTs already have. The whole thing are documents written for OTs. So what we want to do is define what OTs can do, not what other professionals can do, but what OTs can do. And again, I just want to stress, they have to come in to be eligible to even prepare for this. They have to have 3,000 hours of experience working with adults with disabilities. So here's the other hot topic I'm going to just bring up, is kind of the scope of practice overlap. I've heard a lot of questions about this. And I'm going to give a couple of examples here and then talk a little bit more about how I think it applies to O&Ms as well. So if you think of an HVAC person, right? Heating, cooling, and ventilation. Well, they also do electrical and plumbing. And so there's overlap there. If you look at medical examples, who does back surgery? Well, an orthopedic could do back surgery, or a neurologist could do back surgery. So you kind of have two overlapping people that may do back surgery. If you look at the management of hypertension, it might be the same thing, right? It could be an internist or a primary care doctor, but it also might be a cardiologist who is addressing issues with hypertension. So there are lots of professions that have some overlap. So my question to all of you is, who addresses glare? I would argue that all of us address glare. An ophthalmologist or optometrist might address glare. An orientation and mobility specialist might address glare. A CVRT, a vision rehab therapist, might address glare. A teacher of the visually impaired could address glare. A low vision therapist can address glare. And an OT is going to address glare. Everybody addresses glare, and you're addressing it based on what you're doing with that client. And so it's just something to kind of keep in the back of your head as we go through this, and people start thinking about there's overlap to some parts of scopes of practice. So now one of the terms that I think has everybody worried is this community mobility term that OTs use. And so, I have both hats on when I do this, but I want to define a little bit what this means to the OT. So in our practice framework, so that is a document that guides our what we do as OTs. It defines community mobility as it involves planning and moving around the community using various transportation methods, including public or private transportation, walking, accessing, and riding buses, etc. So that's defined as part of our role as an OT. So to our documents, to this certification documents, we added to that definition for participation in valued activities such as grocery shopping, using public transportation, financial management. So we're addressing community mobility and transportation or whatever as it relates to the functional tasks that the patient is doing. And so if we talk just some examples, kind of from the OT perspective, and this comes from an article that was in our practice magazine. So it might be driving, and that could be a car. It could be a power wheelchair. It might be a motorized scooter. It could be a golf cart. It might be a bicycle. All those things could involve driving. We might also look at driving alternatives, and that might be community or public transit. It might be ADA paratransit. It might be hired driver options. It could be volunteer driver programs, or it might be walking. So from an OT perspective, we might be looking at their strength and endurance, physical components of doing, whatever it is that they're doing. And we might be looking at cognitive components. So we might be looking, and there's more than this, but this is just a couple of examples. We might be looking at their sequencing skills. We might be looking at their problem solving skills. We might be looking at mental flexibility. We might be looking at safety and judgment. There might be visual perception skills that we're looking at, that has to do with spatial relations, or it has to do with visual memory or visual discrimination. So there's lots of skills that we might address. Now, I know this is a super busy slide, but when I talk about taking somebody grocery shopping, this is what's going through my head. What is the best day to go? How are you going to get there? Have you looked up your transportation number or the bus schedule? Can you read the phone number or the bus schedule? How about calling to schedule a ride? Some people are not comfortable doing that, and so maybe they need to practice. Have they written it on their calendar? Not only that that's the day they're going grocery shopping, but somehow having a system so they know they've already scheduled the transportation. Can they read their calendar once they've written something on it? Have they created a shopping list? Are they going to set an alarm to get up in the morning? And can they manage that on their own? Are they going to eat before they go? Because if they're diabetic, that's super important maybe. Are they going to wear appropriate footwear for the outing? Can they read the shopping list that they wrote out once they get to the store? How is their scanning? Are they going to be able to scan in the fruit and vegetable section and by the store shelves? Because that's important too. There might be glare control issues inside or outside of the store, right? They might have to read price tags, labels, signs. And what do they do if their store is out of their usual brand of something? Like, how do they react to that? And what's going to happen? Do they get confused? What's going on with their cognition for that? What do they do if they can't find what they're looking for? Can they keep track of prices for their budget? How do they do navigating the checkout? And that might be unloading the cart. It might be handling bags to get them back into the cart. It might be managing the payment. Do they have to call for pickup? And are they going to be able to remember that and handle that? What about their ergonomics and their energy level to transport everything home and get it to their second floor apartment? And what about organizing their fridge or their shelves at home? So for me as an OT, there's a ton that's going into just a grocery shopping trip. And we didn't even really talk about, I talked a little bit about transportation, but we didn't talk about if they have to walk there, right? And so there's any number of things that might be going through my head when it comes to grocery shopping as a community mobility task. It's not just walking there or how I'm going to get there. So the last thing I'm going to say about, I think the clinical competencies is just that the number of competencies in this certification are vast. And there are 72 competencies that we want OTs to have in order to get this certification. Compared to, there's 14 as an O&M, there's 21 as a CLVT, and 34 that are outlined for certified vision rehab therapists. And this was done very much on purpose, but it was very much so that it is very well defined of what OTs need to have skills in before they get this certification, so that they, in order to pass the test, these are the skills that you have to have. And so here's just an example of some of these competencies. I think I said it was 7 pages, maybe it's only 6. But just kind of examples of what some of them are. And you guys can pull up the document off of ACVREP in order to read a little bit more about them. So what else should you know about it? I guess in the back, just from listening to comments over the past couple months and things, just remember that the documents are written for the OT applicant. It really defines what the OT can do and builds on the skills that the OT possesses. We are not defining what other professionals can do. We're not saying what they can do or what they can't do. Just because it's in our scope of practice doesn't mean that somebody else can't address it as well. So think about glare control, right? That it crosses over to everybody's scope of practice. And then the second thing to remember, or another thing to remember, is that OTs already work as part of a multidisciplinary or interdisciplinary team. They are used to referring to other people, and that's good for the vision rehab field. It's good for blindness and vision impairment in general and other professionals who work in that field, because they will refer, and in turn, referrals to O&Ms will increase. So per Kathy Zeider's email, which was sent out on to all certificants on the 16th of January, ACV is committed to developing this certification. And that is something I am super duper thankful for, because I do think it's needed. And then the last thing is that the comment period is open till January 30th. And it's really an opportunity to help give some constructive criticism of where can we improve. We want to know if there's things that maybe need to be defined a little better or something like that. We worked hard with an advisory committee, which had several meetings with just the O&Ms from that committee in order to define things and refine wording and things like that. So if there are other things that can be improved, we want to know about them. And then the next steps is that once the public comment has closed, ACV REP board and then our SME, which is the subject matter expert committee, is going to review all the feedback. And then once that's done, we'll make some revisions to the documents, and then eventually we will start writing that certification exam. And then beta testing will have to occur on the exam as well. So we still have a ways to go to finalize everything with this certification. So I mentioned some of these already, but I think some of the benefits of this certification to in general to the profession is that it's going to increase access to services, but it's also going to reduce wait times for consumers, right? Hopefully that if an OT can do a couple sessions with patient and get them started, maybe start working on scanning and things like that, so that when they get to the O&M, they've already got some good base skills to get there, and then work with the O&M. So I think it also that it's going to offer opportunities for collaboration in a couple of different ways. I think it gives O&Ms, VRTs, vision rehab, certified low vision therapists, the vision rehab professionals that are currently there. It gives them great opportunity to educate the OTs on what they can do. And so I think it offers opportunity for great discussions going on, just so that so that everybody learns to work together and refer to each other, right? Because I think there are things that OTs can help for your patients as well. Just like if I see a patient as an O&M who has, you know, concerning balance issues, I'm going to refer to a PT to address that. And so it's kind of a good thing. And then the PT refers back to me, right? But every time I do that, it's an opportunity to speak to that PT and explain what it is I do as an O&M and how I can help other patients that have visual impairments. So that is great, and often I get referrals from those PTs then. So I think as O&Ms, we can make the OTs aware of our role, and let them know what we can do. I think that we have a chance to provide some great education and training, not only to the people who are certified, but just OTs in general, and let them know that, hey, we're out there. We can develop technical skills by learning from the OTs too, right? They might be able to teach us some things about sensory and balance and things like that. In general, I think everybody's referrals will go up, whether you're on the OT side or on the O&M or VRT side as well. But I think it's also an opportunity to provide some cost savings, right? If we can share a patient and I can do some things so you don't have to do it later, then that might be beneficial, especially if my revenue is coming from a different stream than what your revenue is coming from. So I do think that there are opportunities, and there's probably more than just these things that I can think of. So I want to leave you just with a couple of quotes. Change does not change tradition. It strengthens it. Change is a challenge and an opportunity, not a threat. And Prince Philip of England said that. And Benjamin Franklin said, when you finish changing, you are finished. And I think that's strong. And as a profession, that one we need to remember, that we do need to change. Otherwise, we will be finished. So the last thing is, I think we have plenty of time for questions. So
Yeah, thank you, Anne.
no,
So
no
people
problem.
can either raise their hand, or if you want to put questions in the chat, you're welcome to do that. Uh, Anyone that wants to speak, that is perfectly fine. We're going to try and limit it to 60 seconds per question or comment, just to at least till we make sure we get through everyone's questions. Is there anyone that would like to start?
I did such a great job. Nobody has any questions.
Feel like that's never the case.
I'll go first.
Sure. Go ahead, Eric.
Hey there, Annie. How are you? Thank you for coming and
Good.
doing this today. I really do appreciate that. Um, I'm a GDMI of 13 years and now an O&M of 6 years. I went through the UMass program. Did my internship at Helen Keller National Center for deafblind individuals. So when I heard about this, of course, I had concerns regarding the education or lack thereof in order to grab or get this certification. But then the second thought that I came up with was during what you were talking about is that in order for you to work with somebody with a visual impairment as an OT, you have to have a doctor's referral. Is that correct?
We do. Yeah, we have to work under any OT. It doesn't matter if you
Right.
work with vision or you work with you know, somebody who's been paralyzed in a car accident.
Right.
We have to work under doctor's orders. So, and many people, like in my setting, and people who are now currently CLVTs are working with a doctor, with an optometrist or an ophthalmologist. So,
Right. So then my next question would be is, well, maybe not a question, more of a statement. So then I would assume that to provide services, say for what I would provide, O&M, you would be you would be charging Medicaid, Medicare.
as an O&M, I cannot bill Medicare or Medicaid for those services
So
because
if you're an
that
OT providing services, visual services, O&M services, or VRT services, you will not be providing you. There
An
will be
OT is
no.
an OT is not going to provide VRT or O&M services. We are not going to do the same thing that you guys do. We might touch on some of it, but we're not going to provide. It's not going to be what I do as an O&M is totally different than what I do as an OT.
Right, but I'm
Um,
saying under the new certification.
Under the new certification, I'm still not going to provide what an O&M does. I might, there might be a little bit of crossover, but I can't
So I
teach people as
I
an
didn't see
OT.
any. Yeah,
Yeah. As an OT, I'm not going to teach people to cross streets. I'm not going to teach them to use a long cane. As that being said, somebody who has no vision at all, I'm not going to do any of that
mm,
with, right? So there is, so I cannot bill for it. I
okay,
might talk to them about safety, so it's really it, it's like I have to take one hat off and put the other one on kind of a
sure,
thing.
sure, yeah,
It's so currently in my role right now, I'm an OT and I'm an O&M. When
yeah,
I go out to do O&M, it is a line in the sand. I take that hat off. I cannot bill for that service
sure, okay,
because Medicare defines, what I can bill for and what I can't
yeah.
bill
There's
for.
like codes and stuff, right?
Yep, yep. So
So
you have to follow codes.
the reason for the confusion is because the language in what ACVREP has put out seemed to suggest that the new certification would be teaching O&M and teaching Braille skills and things
No,
like
it
that.
specifically says that we will be referring for Braille literacy skills and we will be referring for long cane training, specifically in the document.
So then what would be the purpose of the certification? And
Because
maybe I'm
there's,
missing something.
yeah, I mean, there's still a lot that we can do with a patient. There's still a
Hmm.
ton that we can do with a patient. And there's many patients who have multiple disabilities.
Yeah.
They may have cognitive problems, they may have sensory issues that an OT can address as well.
Hmm.
And so, there are enough OTs interested in vision rehab services that we would like to have a certification to show that we have the skills to provide, these services.
So no OTs would be teaching O&M or VRT skills.
No,
Okay. All right.
no
Thank you
ways.
for the
Yeah.
clarification.
I mean, by VRT, it's Braille. There's going to be some crossover, but we are not going
Mhm.
to be teaching Braille literacy or anything like that.
I
So
mean, because I'm sure, as you know, I
even
mean, O&Ms for a long time have been lobbying to be able to be licensed and be able to be available to clients so we can
mhm,
increase access to services. But
mhm.
I mean, to no avail, we have received
Right. Right. Medicare
no,
is not in the habit of adding providers at this point in
right,
time.
right.
They want to
Okay.
cut services, not add. services. So,
It seems like that's kind of going around, right? Yeah.
yep. Yeah.
Thanks for the
Thank you,
question,
Amy.
Eric.
I appreciate it. Thank you.
There is a question in the chat from Desmond. Would there be a pathway for COTAs? I guess that's Certified Occupational Therapy Assistants, maybe, to get
Mhm.
this certification?
I don't know at this point. I'm not sure that we've addressed it. We're just one step at a time. Down the road, we might look at that, but we're just
Okay.
trying to get through this one.
Uh, other people, other questions? All right, Maggie.
Yes, hi, thank you. So Annie, here in Michigan, we can work with, or we work with students in the school system up to the age of 26.
Mhm.
Can you tell me in the new criteria, how are OTs defining adult?
It's not defined in the new criteria. I would guess it's over the age of 18 as an adult. If they're getting services in the school system still, then OTs will likely work with school system intermediate school districts or whoever that they might be getting services from. If they're getting the services through age 26, it's likely those are not new services. They've been getting those for a while. And some of that, again, is going to be collaboration with the optometrist, the ophthalmologist who's seeing the patient, the eye care professional as well, who's seeing the patient to make sure that they get routed into the people who can service them. It's not in patients' benefits. It's not in their benefit to use medical insurance sometimes. So there's many times where, like, for instance, somebody comes in and they don't have coverage for OT services, or they don't have coverage. They get one session with me, an eval, and that's it. So oftentimes we have to route them to other services that can provide, whether it's state agencies for the blind, whether it's private agencies for the blind, school systems, wherever, we can get them services. So it's not always super beneficial. Everyone thinks it's great to bill medical insurances. It's not always so great.
Okay, thank you. So, could it then be possible that a CVROT in the future could end up on a student's IEP as a service provider?
I think it's possible, but not likely. It personally, and this is me, I think where you are going to see most OTs working with people with visual impairments will be with that older adult population. I think probably over the age of 50 is a good guess. That's really where I think the majority of us will work.
So I do have a question from Jamie. As she referenced, there's a little too much there to read, but the self-study pathway reference for the CLVT certification, but like CADIS, CVRT, and COMS don't have any kind of self-study path. So how does a self-study pathway support acquisition of skills that have like safety implications, and particularly those for community mobility?
So I think that um, I think that your the one thing that's forgotten in here is that self-study pathway has a mentor. So it has somebody who's already certified and is mentoring somebody. So that mentor is going to help guide what they need to study, what skills they need to have. They're the ones who are checking them off on those 72 competencies and that type of thing. So
And
that's one assurance that these people are are getting the skills that they need to work with this population.
And is
What was
that
that, Justin?
something that can be done remotely? Like, is there any in-person aspect to that? Do
Well,
they undergo like,
if you look at the competency sheets, you actually have to check off how you know that they've acquired that skill. So you have to check off, are they, hang on, I'm going to grab it here so I don't say it wrong. What's the method that was used to acquire that skill? Is it, hang on, sorry. Was it done by test, by observation, by a video, by a demonstration, verbally, or by a chart audit? Like, how did you figure out as a mentor that they acquired this skill? And so that's a little higher level than VRTs, O&M, CLVTs are held to, is the mentor is really responsible when they sign their name to this form that they have this skill.
oh, true. I mean, but all those also undergo like a 350-hour internship specific to vision.
CLVTs have a 350 hour.
Yeah, okay. Well, I'm okay, just clarifying. And so the other question, how would a CVROT address walking in their community without teaching street crossings? Or like if a trip to the grocery store, can that still include street crossings? How does that work? These are some of the questions from the chat. Does that make sense?
I think Ant's frozen,
Computer's
Justin.
frozen.
Okay, I thought I was frozen for a second.
No, Annie's
You look
frozen.
okay. Annie's frozen, yeah. Here, she's coming back in though, I think. Yeah. Yeah, here she comes. She's still connecting to audio.
Sorry, I made it through most of it.
Sorry about that.
There's always
Uh,
one person in the group, right, who has
yeah.
that issue.
So I think the question was if they're doing a trip to the grocery store as part of community mobility, there just can't be any street crossings as part of that, or how
Well,
would
I mean,
they do
I
that?
think we would, I think, is the patient already crossing streets because they have enough vision to do it, right? And some patients do have a MAC-DGen patient has quite a bit of vision. And so that might be one thing. It might be, but I would say that most of our older adults aren't walking to the grocery store. There are some, but a lot of them are not walking to the grocery store. So I do think, but it's likely the OT. It depends on the setting that they're working in. We may not be able to go out like that into the community with them if we're clinic based.
Okay.
So I mean, I think a majority of us are clinic based, and so we can't just go out into the community with them. We can mock up a grocery store in our office,
Hmm.
but we might be able to meet them at the grocery store, but we can't walk with them to the grocery store necessarily.
So I think the question is like, I mean, it kind of talks a little bit about like if they need to use pedestrian signals or as it talks about community mobility. I mean, at that point, if someone is going to be traveling in those environments, wouldn't it make sense for it
We
to
would
involve?
we would refer to an O&M for that. I mean, if it
Okay.
involves walking, if it involves using pedestrian signals, I would say if it's anything more than crossing a street,
Did
it
we
needs to have
lose
an
her
O&M
again?
involved.
Oh, there. Okay.
Nope, I'm
So
here. Sorry.
I I think the question is, I guess, if it's specific on they have to be referred for cane travel, why wouldn't it also specify for like those kind of complex environments?
Because I think there's a couple of reasons why. The Our advisory committee did not feel it was necessary. Because remember, we're not defining what an O&M can do. We're defining what is within the OT's realm to do. But I also think that there's not an O&M in every community. So then what happens? Then what happens? I'm not
I
saying
think that's the question.
I'm not saying that an OT should go out and do cane training, but it is a fair question. There may not be a mobility specialist in every single community.
And I know a couple people.
This is one I think we can debate on. I don't
Yeah.
have a good answer for it.
Ellie, I think you have your hand up.
Hi, Deli Carlson. Just wanted to share that I'm a independent O&M and GDMI in Colorado, and for 20 years, I just looked at when I was first referred. There's a low vision clinic, very medical model that serves statewide here in Colorado, and they have ophthalmologists and OTs, and they refer out to folks like me for O&M, and it's been a really good experience within some limitations. I will say that because of the nature of the medical model, the majority, all of their patients, they are only eligible through an eye exam, meaning they have low vision and they're receiving treatment. So it attracts more seniors with age-related vision loss and kind of the foundation fighting blindness folks who want genetic testing and cures and things. And that's fantastic. And I'm glad we have a home for them. But it's very not inclusive for our folks that are congenitively blind or acquire total blindness. So it's great that in my state, we are a informed choice, and we have the Colorado Center for the Blind and other avenues to fill all those needs. But yeah, we've even been doing presentations to the OT students at Colorado State University. The OT will come in, I will come in, we'll talk about our roles and how we refer back and forth and where we draw those lines. So it's been successful here in Colorado. I'm not worried about this. I appreciate the help.
Thank you. And Erin Buckley.
Hi, yes. Can you hear me?
Yeah.
Okay. So I'm up in north of Boston, and I work in the schools, and I would say, hearing all sides of this issue or this idea has been informative, and I appreciate this opportunity to talk with you. So working with kids in the schools is where my focus is. And I understand that the idea is that it's mostly going to be working with people who are older, but how is it? I work a lot with OTs as it is what I'm saying. So how do I draw the line between an OT that might try to get this certification, that might want to do mobility in the schools, as opposed to what you're suggesting? And I couldn't tune in at the very beginning, so I'm sorry if I missed something.
So I think the certification is only for OTs who are working with adults. And one of the requirement is that they have worked with adults for 3,000 hours in the past 5 years.
Okay, I did hear that. How can you make sure that, if somebody says, well, I have the certification, and I'm going to do it in the schools, how do we know that people won't be?
Well, they're going to have to get a letter from their employer saying that, yes, I've worked 3,000 hours with adults.
But I'm saying with children. What my feeling is wondering if people are going to come into the schools and say, well, yes, I am a mobility specialist, and people will say, okay, and let you do some mobility.
No,
all right, there are safeguards against that.
I think, I think OTs in general are very aware. Don't forget that we work a lot with PTs, and there's the same kind of territorial pull with PTs and OTs, and speech therapists and OTs. So OTs are very aware of their scope of practice, I think. Okay. It's just, we kind of have our box and we stay in it, and we know what we can do and what we can't do. But we also, I think OTs are great at recognizing what we're not skilled at. And so I go out and find that help for my patients, right? So I know I'm not great at maybe addressing balance. And so I need to go out and maybe refer that patient to more PT. Or if I see somebody who's got some cognitive issues that haven't been addressed, that might need to go to a speech therapist, so we're very used to cross referring, but I think we also recognize when we don't have the skill level to address something correctly for the patient. And maybe that's something that licensure does a little bit for you, because it makes you worried about getting sued.
Okay.
And crossing those boundaries, that type of thing. So
Okay, that makes sense. And I don't want to sound like I'm completely being territorial, because, and I get that too. I also, the first thought was, wait a minute, what are you talking about? But we have such a shortage that I would love to have people help us out in some ways, but I just know I don't, on the other side of the coin, when people talk about, that it could be kind of watered down, or
right.
I know
Right.
you're not going to create a program like that, but you know what I mean?
No, and there's language. I think there's language in if you look at the scope of practice document that talks about working with an O&M to learn more, to hone in on your skills. And if you have an O&M in your community, talk to that O&M about what you can do and what you shouldn't be doing. At what point do they want the referrals to you? So there is some language in that, the scope of practice. I think it's the scope of practice document.
Okay, thanks very much.
Do we have anyone else, Justin?
Anyone raise their hands? There's some stuff in the chat that I'm trying to see how I can.
Yep, I know. I know Kathy Zeider has asked that everyone to submit public comments if they feel that wording in the scope of practice, for instance, should be revised in order to clarify things. Is there a reason that the literature does not use CCOMs but regularly mentions referring to nationally certified O&Ms? I guess I'm not sure which literature.
In the proposal, it talks about nationally certified
I think
O&M
that's
specialists.
because in some countries, because we had to think internationally, so we actually had somebody on the board from Canada, and for some reason, I think they have another way to certify certain people, and I don't know if it's O&M or not, but that's the only reason I can think of. But somebody should write that in the comments, and we'll look at it again.
Yeah, I think Kathy mentioned it too, kind of leaving the possibility that could be a COMS or NOMC.
Yes. Yeah, maybe that's it. Yep. Somebody said that. So.
Any other questions?
So I do, as just at the end here, just to say, I do think it's a great opportunity for comms to really, really talk to OTs about what they do, so that everybody understands each other. Because I think that's part of some of the things is there's some terminology differences, and there's some things that we don't understand about each other, I guess is a good way to put it. And I know that from working with OTs and being an O&M, and what they don't understand about O&M and things like that. So I think there's room on both ends for everybody to learn.
I did just have one last question. And do you know why AOTA stopped doing the low vision certification?
They have never really given us a reason of why, except that they dropped several specialty certifications. So they had two categories of certifications. They had specialty certifications and board certifications. So they kept the board certifications and dropped the specialty certifications. So it was low vision, but it was also a couple other certifications that got dropped.
Okay. And I saw one last comment just about quiet residential street crossings, I guess, are kind of listed as like low risk activities, which I think someone found concerning. And
I don't, yeah. I mean, I think it depends. Again, my my response to that is maybe it depends on the person. It depends on how much residual vision they have. It depends on what they want to do, right? But I do know that OTs will refer to O&Ms. So so
okay.
somebody asked, I'm going to address one other thing. So
Yep.
somebody asked, O&M is equated to long keen instruction. Was that intentional or was it an oversight? That was wording that was specifically that the O&Ms on the advisory committee specifically asked us to add. And so we added it. That's why it's worded that way. We originally were not going to write long keen training, and they specifically wanted it in there because we know the people on the committee know O&Ms do a lot more than just long keen training. So
And so we will share the recording of this presentation. I think we should have that available to send out.
Unless
Uh,
someone screws it up, yes.
okay.
And Kathy has her hand up, by the way, Justin, I don't know if you see her.
Oh, Kathy.
I just wanted to mention, I was on a call with a ODA, and where ACVRP has always determined certification by the passage of a rigorous certification exam, and those are very expensive. When a ODA made the decision with their board certifications to move to certification exams, they had to make that determination of which ones they were going to be able to financially support with that certification process and in what order. And they also very clearly said that in looking at those they kept and those they didn't, they looked at whether or not there were other organizations already in that space doing certification well.
Thank you, Kathy.
well, again, Justin and Lucas, thanks so much for having me. I appreciate it.
And
Yep.
Amy asked if it would be to have access to the PowerPoint presentation. This entire presentation, including the PowerPoint, again, unless I screw it up, will be up on the USOMSA website. That is under the Resources tab. You have to scroll all the way down the page past a lot of other stuff, and there's a bunch of links there at the bottom, and one of them is to a LiveBinder site, and that's where this presentation will be under 2025 presentations, I hope.
I just posted a link to the resources part of that, at least from
Thank
there.
you.
Of course, it won't be posted yet, but by tomorrow,
With,
probably.
with luck, yes.
And just a reminder, the comment period for this ends on the 30th. Is that right,
Correct.
Kathy? Okay.
Mm-hmm.
Yeah. All right. Well, thank you all very much, and we really appreciate it.
Great. Thanks.
Thanks again, Ann.
Have a great
Thanks,
night,
Annie.
everyone.
Good seeing you.
You too. Thanks, Eileen.